Let's study the chapter Physiological Changes During Pregnancy. The maternal adaptation undergoes in anatomically as well as physiologically and biochemically, not only in the reproductive system but also in all the other systems of the pregnant woman to suit the increasing demands of the fetus. Coming to the genital organs, in that vulva becomes edematous, it becomes hypertrophied and also vascular. There is pigmentation of, particularly there is pigmentation of the labia minora, and superficial varicosities develop, particularly in the case of the multipara women. Coming to vagina also becomes edematous. It also gets hypertrophied and also vascular. There is something called as Jacquemer sign. This Jacquemer sign, also called as the Chadwick sign, is relating to the bluish discoloration of the mucosa of the walls of the mucosa of the walls of the cervix as well as of that of the anterior vaginal wall. And one more important characteristic the anterior vaginal wall undergoes during the pregnancy is that it undergoes lengthening also. Coming to the secretions are thin, copious, and they are curdy white. And these secretions will consist of two types of cells. The first type of cells are the exfoliated cells, and the second type of cells are the bacterial cells. The bacterial cells are the lactobacillus acidophilus bacteria, and this bacteria makes the secretion acidic in nature with a pH of approximately 3.5 to 6. And this bacteria converts the glycogen into lactic acid. Since it is acidic in nature, therefore it prevents the proliferation of other pathogenic organisms. Basically, remember that all this secretional concept is due to the increased estrogen levels. That is, the hormone estrogen is responsible for the acidic secretion during the pregnancy. Which hormone? That is estrogen. Coming to changes in the uterus from a non-pregnant state to a pregnant state undergoes drastic changes. For example, it just weighs 60 gram in non-pregnant state, but it becomes 1 kg in the pregnant state, and 2 by 3 by 4 inches in non-pregnant means 4 by 5 by 8 inches in the pregnant state. And if it was having a volume of just 5 to 10 ml, then it changes by approximately 1000 to it approximately changes by 1000 times. That is, an increase in 1000 times by volume takes place to accommodate 5000 to 10,000 ml, or just 5 liter to 10 liters of volume can be accommodated in the pregnant uterus. Coming to the different parts of the uterus, they are the body, isthmus, and the cervix. Let's study first about the body of the uterus. The body of the uterus undergoes increase in the growth as well as there is enlargement, and this growth and enlargement is seen in terms of hypertrophy of the uterus as well as hyperplasia of the uterus. Hypertrophy means there is increase in the size of the cells of the uterus. Hyperplasia means there is increase in the number of cells of the uterus, and all this is a hormonal stimulation. The hormones are, involved here are the estrogen and progesterone. The hypertrophy occurs beyond 20 weeks also. That is, increase in the size of the cells can occur beyond 20 weeks. That is, it can even cross that is it can hypertrophy even after the first term, that is till 1 to 12 weeks. And but the hyperplasia, which is increase in the number of cells, can take place only till the end of the first term of the pregnancy. And remember that the uterus has outer longitudinal fibers which hook over the fundus of the uterus, and it has inner circular fibers, and there is intermediate fibers also in the uterus which are crisscrossing in nature. And all these three types of muscle fibers, when they occlude, that means when these muscles contract, they will occlude the blood vessels that are going to pass through them, and that forms living ligature in the uterus. Coming to the vascular system, in a non-pregnant woman, the uterine artery is the main artery to supply the uterus. But in the pregnant woman, there is also a very important role played by the ovarian artery, where it supplies equal amount of blood as supplied by the uterine artery only. And one more important change that you notice in the arteries of the pregnant uterus is that it undergoes spiraling. As well as lengthening up to 20 weeks of pregnancy. And after this 20 weeks of pregnancy, and this will undergo straightening of the arteries takes place. And the Doppler velocitometry has found that there is increase in diameter by about twice, as well as the blood flow has been increased by 8 times in a pregnant uterus. And there is dilation and of the veins, as well as the veins become valveless in the uterus to allow faster flow and a better flow of blood. And there is also numerous lymphatic channel also get opened up here at this point. And very important point to note is that this vascularization is maximum at the placental side. This vascularization is maximum at placental site. And there is the fundus enlarges more than the body. Coming to weight of the uterus, it rapidly increases, as is evident that there is conversion from a 60-gram uterus to a 1000-gram uterus, and all this is due to, as we have already read, is due to the muscles increase in the muscle, that is hypertrophy and hyperplasia of the uterine muscles, and the increase in the vascularity of the uterus, as well as due to the increase in the connective tissues in the uterus. Coming to the relation, in the relation we'll talk about the shape. And the shape of the normal uterus, normal non-pregnant uterus, is pyriform in nature, but by the end of 12 weeks, that is by the end of first term, it becomes a globular uterus. But by the end of the second term, that is by the end of 28 weeks, it becomes once again a pyriform or an ovoid one, depending on the lie. And this at the stage of 36th week, it becomes a spherical one. Coming to the position of the uterus is in an anteverted position, that is, it is in this way. And once it starts to enlarge, it becomes an abdominal organ also, due to which it presses on the urinary bladder. As a result of the pressing of the uterus over the urinary bladder, the frequency of micturition becomes a troublesome one. Later in the third term, once again there is erection of this anteverted position, due to further enlargement of the uterus. And this will be much evident in the case of primigravida, because in primigravida the abdominal muscles are not lax, they are tight. So as a result of it, they can resist the enlargement of the uterus, due to which it can be the uterus, that is the anteverted uterus, get pushed up and becomes erect. But this will be less pronounced, I mean the frequency of micturition becomes less troublesome in at third term in multiparal women, because there the abdominal muscles are little bit lax, that means they are not so tight. As a result of it, it still remains pressed on the urinary bladder, making it little bit troublesome compared to the primiparal pregnants. Coming to the lateral obliquity, there is a dextrorotation of the uterus in the lateral, um, um, and this dextrorotation of the uterus, that is clockwise rotation of the uterus, is due to the presence of the rectosigmoid colon in the left posterior part of the maternal pelvis. Let me repeat. There is dextrorotation of the uterus due to the presence of the rectosigmoid colon in the left posterior part of the maternal pelvis, and as a result of it, the left cornua of the uterus comes to the forefront, touching the abdominal wall, and due to this turning, even the cervix becomes turned in the opposite side, and it makes a levo rotation, which brings it closer to the ureter. Coming to the concept of the Braxton Hicks contractions, the Braxton Hicks contractions are the irregular, infrequent, spasmodic, and painless contractions without any effect on the dilation of the uterus, and these contractions become of increasing intensity, increasing duration, and increasing discomfort, leading to the labor pains. These contractions are felt as early as 6 weeks of pregnancy, and they will be having an they create an initial intrauterine pressure of less than 8 mm of Hg. And this uterine contraction can also be elicited by the bimanual palpations, and by rubbing the uterus. Rubbing the uterus stimulates these uterine contractions, and very important characteristic of this uterine contraction is that they become firm, and they make the uterus firm during the contraction, and when they get relaxed, there is softening of the uterus. Coming to the importance of this contraction on under will cause partial occlusion of the arteries of the uterus, and complete occlusion of the veins, and this causes decreased placental perfusion, due to which there is a fetal hypoxia, because fetus is in urgent need and very much need of the flow of blood that is taking place through the placenta, and due to this decreased placental perfusion and hypoxia, there is also bradycardia noticed in the fetal heart, as a result of which we say that whenever there is contractions of the uterus, there is a decrease in the fetal heart sounds, which is indicative of bradycardia. The Braxton Hicks contractions are not seen in the abdominal pregnancies. Coming to the isthmus, there is a hypertrophy here also by 3 times. This isthmus is relating to the isthmus of the uterus, and this is extremely important to because this region of the uterus acts as a connector between the cervix and the body of the uterus, and it has sphinctering muscles, and these sphinctering muscles are responsible to hold the fetus within the uterus itself. The incompetency of the sphincter leads even to mid trimester abortions also. To avoid all this, the modern surgery includes the encirclage surgery, which rectifies this incompetency of the muscles of the of the isthmus of the uterus, and restoration of the retentive function of the isthmus. Coming to the cervix also undergoes hypertrophy and hyperplasia. Coming to the cervix of the cervix, as I have already told, that is, it undergoes hypertrophy and hyperplasia, and this hypertrophy and hyperplasia is seen in four things. The first is the elastic and connective tissues undergo, and there is also increased vascularity beneath the portio vaginalis, and this is responsible for increased vascularity in the cervix, and making it having a bluish discoloration. Remember that the highly increased vascularity makes the mucosa bluish in discolor color, and this is called as the Jacquemer sign, or also called as the Chadwick sign. And one more hypertrophy is that of the glands of the uterus, which cover the bulk of the mucosa, and this response is responsible for making the cervix soft. And this softening of the cervix is called as the Goodell sign, and it can take place as early as 6 weeks. And remember that the bluish discoloration, which is the Jacquemer sign, can take place as earlier as 8 weeks. And what is the importance of this signs is that they act as a diagnostic aid. That is the first point. The second point is that due to this increased vascularity, as well as of the hypertrophy and hyperplasia of the glands and the connective tissues, causes helps in dilatation of the cervix very easily during the labor. And this vascularity will spread from below upwards. Remember that the vascularity will spread from below upwards. Coming to the epithelium of the cervix, the cervix undergoes a marked proliferation in the downward direction of the endocervical mucosa. The squamous cells sometimes become hyperactive, and they even enter the columnar vaginal region, and this can simulate basal cell hyperplasia, or it can even cause the cervical intraepithelial neoplasia can be caused. Coming to the secretion, these secretions are particularly due to the progesterone stimulation, and what happens in this secretion is that there is a physiological leukorrhea. There is a physiological leukorrhea happens during the pregnancy. Okay. And this mucus is rich in immunoglobulins, as well as in the cytokines. It is rich in the immunoglobulins, as well as it is also rich in the cytokines. Okay. And it not only fills up the glands, but it is very important to form the cervical plug to retain the fetus in the uterus also. Coming to the anatomical changes, there is no much lengthening of the cervix, but the bulk of the cervix becomes dilated, and there is variable amount of effacement of the cervix also taking place. Coming to the fallopian tubes, of course, the fallopian tubes undergo hypertrophy, but not as much as the fundus undergoes. As a result of which, though the fallopian tube grows by the hypertrophy of its muscles, but still the tube remains congested due to the extreme enlargement of the fundus of the uterus. As a result of which, the tubal ostia, which was lying above the fundus in the non-pregnant women, now becomes lower compared to the pregnant fundus of the uterus. Okay. And this remember that the epithelium becomes flattened here, and there are patches of decidual reaction, not complete decidual reaction. There is patches of decidual reactions taking place in the fallopian tubes, which will be dealt little bit later. Coming to the ovaries start to produce HCG, and there will be also production of the estrogen and the progesterone by the corpus luteum, and this is called as the luteinization reactions takes place. And these luteinization reactions are responsible for both the ovarian and uterine cycles to remain suspended. And remember that the luteoma of pregnancy is due to the exaggerated luteinization reactions that take place in the ovaries. The pregnant ovaries remain orange in color. Later, they become paler and paler to become yellow in color. And let's study the two important anomalies, or two important reactions that happen in the pregnancy. That is, the first is decidual reaction, and second is the luteoma of the pregnancy. Decidual reaction is a metaplastic change that covers the ovary with a patchy sheet of decidual cells, which is due to the increased amounts of the hormonal secretions. And luteoma of pregnancy is due to the exaggerated luteinization reactions of the ovary. Coming to the breasts, The changes that take place during pregnancy to the breast are best evident in primigravida or those multigravidal women who have not lactated yet. And coming to the size of the breast, and the size of the breast undergoes hypertrophy as well as proliferation, and there is proliferation in the ducts, also in the alveoli, also in the stroma and connective tissue, and even in the myoepithelial cells of the breast. And the ducts undergo the proliferation due to the secretion of estrogen or due to stimulation of the estrogen, and the alveoli undergo the proliferation due to the estrogen as well as the progesterone stimulation. There is increased vascularity and in the breast, as well as there is increased striations of the skin in the breast, and there is establishment of hypertrophy. I mean, there is hypertrophy of the axillary tail of spines due to which the breast become painful as a result of the enlargement. Coming to the nipple and areola, nipple becomes enlarged, it becomes erect and pigmented also. The Montgomery's tubercles, these Montgomery's tubercles are nothing but the sebaceous glands which were invisible or very much minute in the non-pregnant state, but they become enlarged and dilated in the pregnant woman, and they are responsible for production of the sebum, and this sebum is responsible for making the nipple and the areolar region moist, preventing it from dryness. And this is very important in a lactating woman as it prevents sore nipples. And there is also secondary areola which is formed, and this becomes pigmented, and this secondary areola is formed in the second trimester. Secondary areola formed in the second trimester of the pregnancy. Coming to the secretions at 12th week, that is, at 12th week there is sticky colostrum gets produced. Therefore, start of the galactokinesis, that is ejection of the milk or production of the milk, which is called as the lactogenesis, take place in the mammary glands at the 12th week, and these secretions become thicker and yellowish. These become thicker and yellowish at the 16th week, and this is a very important sign of pregnancy, particularly in those women who have never lactated. Coming to the cutaneous changes that take place at the face undergoes something called as in the cloasma gravidarum, also called as the pregnancy mask. And this pregnancy mask is the formation of patchy brown patches, or it might be sometimes even diffuse also. And these will be formed on the particularly the regions of the forehead, the eyes, as well as on the cheeks. It will be usually formed, and this is a very important sign of the second term of the pregnancy. Coming to the second cutaneous changes in the breast, as already said, nipples become pigmented, and there are striations on the breast also. And one more important thing is that there is also a presence of the stria gravidarum, that is the stretch marks also, that is the striations of skin are also found on the breast in the pregnant woman. Coming to the abdominal changes, there are two things, that is, first is the linea nigra and the stria gravidarum. This linea nigra, as the word itself is suggesting, linea means a line and nigra means black. This it is the brownish or brownish to black pigmentation of the skin at the midline of the abdomen, right from the xiphisternum to the pubic symphysis, and this is due to the increased levels of the melanocyte stimulating hormone, or it might be even related to the estrogen and progesterone, which was confirmed by the presence of this linea nigra even in those women who are consuming the oral contraceptives. Coming to the stria gravidarum, the word stria means that is striations, and gravidarum means in a pregnant woman. These are pink colored stretch marks which occur due to the loss of the collagen tissue of the skin, causing formation of the scar tissues at the deeper cutis. And these are initially pink in color, and these are present below the umbilicus, and usually they might even extend to the thighs as well as to the breast. And later, after the delivery, when the obesity comes down, these are called as stria albicans because of the whitish color of these tissues. And this is due to the obliteration of the capillaries by the scar tissue, as a result of which making it glistening and white. The other causes of this stria gravidarum can be obesity, or it might be due to the edema, or it might be due to Cushing syndrome, which is increased aldosterone levels. Some other cutaneous changes include the vascular spider and the palmar erythema, and both of these, vascular spider and palmar erythema, is due to increased estrogen secretions. Some other cutaneous changes include hirsutism, which is the formation of hairs on the facial hairs, and even there is excess hair loss also taking place in the puerperial stage of the puerperial stage. Coming to the concept of the weight gain during pregnancy. In the earlier pregnancy, there might be morning sickness which causes vomiting and nausea, and this can cause a slight decrease in the weight of the pregnant woman. But after that, there is continuous increase in the weight of the woman till it becomes static during the last 2 weeks of the pregnancy. And in a singleton pregnancy, what is a singleton pregnancy? That is when there is only one fetus inside the uterus. There will be an estimated 11 kg gain in weight in a normal BMI woman. And this weight gain can be divided in three parts. In the first trimester, that is till 12 weeks, there will be an increase in weight by just 1 kg, and by the end of second trimester, there might be increase by 5 kgs, and in the third trimester again by 5 kgs. And remember that this 11 kgs weight gain can be due to the reproductive weight gain, and also the maternal weight gain. The reproductive weight gain includes due to the hypertrophy of the reproductive organs like the fetus, placenta, uterus, breast, and the fats and the proteins. The fetus weight will be 3.3 kg at term, and the placental weight will be 0.6 kg. Please note that the ratio between the fetus is to the placenta will be 6 is to 1, and the uterus grows by 1 kg, as I have already told, and breast becomes half kg, and the fats and proteins contribute to 3.5 kg gain of weight in the during the pregnancy. And this is very important because the pregnant woman later needs a very high calorie diet, and if she could not afford for that, these stored fats and proteins can be used up as the stores of the calories. Coming to the maternal weight gain, it can be due to the increased blood volume and increased extracellular fluids. The blood volume increases from 5 liter to 6.5 liters, and this 6.5 liter increase causes a hypervolemia. Hypervolemia implies that there is increased pooling of the blood at the inferior extremities, that is at the legs, particularly below the ankle. As a result of it, there is increased venous pressure created by the hypervolemia. There is pedal edema is very much common in the in the pregnancy. And this pedal edema is going further little bit, and this pedal edema will be particularly common in the right leg because of the compression of the right iliac vein by the uterus, by the growing uterus. As a result of it, there is more edema at the right side of the leg. Coming to the hypernatremia occurs during pregnancy as well as hyperkalemia also, and these increased minerals causes are responsible for the water distribution. And this hypernatremia and hyperkalemia is due to three important hormones. The first is the estrogen, second one will be the aldosterone increase, and third one will be the ADH increase. Rapid weight gain of greater than 0.5 kg per week diagnoses it with the preeclampsia condition, that is increased, which is due to the increased BP in the body. And stationary or falling weight implies that there is growth retardation to the fetus, or there might be some intrauterine death also. If the pre-pregnant CMI BMI is, that is the basal body mass index, is if it is lying in between 20 to 26, that is normal. Then 11 to 16 kg of weight gain is allowed. But if the BMI is greater than 30, that is if she is a obese woman, she should not be allowed to grow by more than 7 kg weight, because obesity causes so many problems both to mother as well as to the growing fetus. And less than 19 BMI, and the woman can be allowed up to 18 kg gain in weight. And all these BMI values imply and give information about the fetal weight and the nutrition of the fetus also. Coming to the body water metabolism, due to the increased blood volume, and particularly due to the increased sodium concentration, that is hypernatremia, there is also increased water accumulation in the body to neutralize according to the Donan equilibrium. As a result of which, increased blood volume is seen in the body of approximately 6.5 liters will be retained in the body. And this water retained is can be divided into two parts. That is, the one which is having 3.5 liters is the fluid volume which is present in the fetus, placenta, and the amniotic fluid. That is, the 3.5 liters here is divided further by the fetus placental volume as well as by the amniotic fluid volume, and the rest of it is belonging to the mother. Coming to the next thing, that is the cause of this was due to the hypervolemia, hyperkalemia, as well as due to hypernatremia also. And this in turn was caused due to the increased hormonal levels. Which were the hormones response? That is estrogen, progesterone, REAs, that is renin, angiotensin, and renin, angiotensin, aldosterone. And yeah, due to the AVP. What do you mean by AVP? AVP is the arginine vasopressin, and ANP as well as the BNP are also responsible for this increased levels. And all these will cause, due to this hypernatremia and hyperkalemia, there is decrease in the osmotic threshold. Due to this decrease in the osmotic threshold, there is increased stimulation to the thirst center, due to which increased thirst also takes place. As a result of which, the pregnant lady drinks more amount of water. Due to excess drinking water, there is also excess excretion of water also, which is can be called as the polyuria condition. Coming to the hematological changes, in this the coming to the blood volume, there is increase in the blood volume, of course. And it will increase from sixth week. It will start to increase from the sixth week, and it will become maximum till 30 to 34 weeks. It reaches its maximum, wherein there is a 50% and above increase taking place to the original, and after this 34 weeks it almost remains static in nature. Coming to the plasma volume, there is increase in the plasma volume from the 6th week till 34th week. There is increase, and this increase will be 1.25, though there is a progressive increase, but this graph is not exactly correct because it is a progressive but inconsistent increase in the plasma volume takes place, after which it becomes a static one. Coming to the this plasma volume will be much greater in case of multigravity, or in case of multiple pregnancies, or in case of the larger babies. All these give rise to what is called as the hemodilution. What is the most important part of this hemodilution is that it prevents the blood loss, it can compensate the excessive blood loss during the delivery. It can even prevent the adverse effects of supine and erect posture changes, and also it ensures faster gaseous exchange because there is increased flow of blood taking place due to this hemodilution as a result of the decreased resistance offered by the formed elements of the blood. Coming to the RBC and hemoglobin count, there is increase by approximately 20 to 30% by mass of RBCs, and to say exactly, there is 350 ml increase in this, and it will start to increase right from 10th week. It will start to increase right from 10th week till it reaches the term. And why is this increasing? It is increasing to achieve the state of the hemodilution. So most important thing in the hematological changes is to remember the concept of hemodilution. There is reticulocytic increase also by 22%, and though the total hemoglobin mass is increased, but still the hemoglobin concentration is decreased due to the hemodilution.